Well, listen, thank you all so much for joining us yet again for one of our FASD awareness webinars. I'm delighted to invite tonight the esteemed consultant clinical psychologist, Cassie Jackson. Thank you, Dr. Cassie, for joining us tonight. I think one of the things that is particularly interesting to me is your involvement, because I know you work with Dr. Raja as well at the clinic, mainly with the hub and spoke model. Is that correct? Yeah. So what's your involvement there? Because I know Raja's a good friend of the charity and our webinar series. So yeah, tell us a little bit about that specifically.
Yeah, so I'm very part-time with the National FASD Clinic, but I'm essentially helping with the hub and spoke model in terms of providing consultation service once a month to medical professionals and social care professionals in different sort of regions in the UK who are sort of signed up into this, have a contract with the hub and spoke model at the Surrey Clinic.
And so, do you find there are more hub and spoke models coming in, and are they being utilised effectively? Because I know we set the first one up down in the southeast with Raja, and it was really hard to try and get those community paediatricians to get engaged with it. Do you find that's still the case, or is it beginning to gain traction?
I think it really is, and I mean, my experience of it is that paediatricians and social care professionals are really enthusiastic about it now. And I really enjoy providing those consultations, and I think there is definitely a growing awareness, and I think it's just a brilliant way of being able to provide that sort of expert FASD consultation, which then enables paediatricians and other professionals to be able to sort of provide diagnosis locally in a much more straightforward way for local children.
You have your own clinic that you are director of. Can you explain, is that where you diagnose for FASD in your clinic as well?
Yeah, so Psychology Clinic of East Anglia, I'm the co-director of PCEA, and we basically have two hats, or two parts of the service really, and I work across both sides. So we've got the expert witness side, which is the side where we clinical psychologists provide an expert witness service to family law, in child protection, care proceedings, that kind of thing, and I do that work as well. And then we've got the neurodevelopmental assessment service, where provide assessments relating to FASD, ASD, ADHD, and also the general sort of neuropsychological assessments. I often see children and young people maybe 3 times over the course of their childhood, actually, for sort of updating neuropsychological assessments to track their sort of trajectory and be able to sort of help, provide a sort of more streamlined sense of what their needs are, what need for support, and particularly at the time of sort of moving towards independence. So yes, the PCA has sort of 2 wings, if you like, and I do both of them. And actually doing both of those is really useful, because it gives me a sense of a lot of the children I see, perhaps in adoptive placements, for example, with FASD, are often the children I see in care proceedings on the other side of the fence, if you like. So I get to see the complexity on both sides and how that looks at different stages, and the bits that get missed sometimes, or the bits that, you can see how complex the system is. And
I think having those 2 hats on, it's something that, working with the grassroots level with the families that we support is something that we would encourage 100%, because it shows an empathy. It's a holistic approach as well towards it, because you understand the condition and you understand the behaviors and how to manage those behaviors. If we're dealing with somebody in a scenario, we spoke just before we started, let's say that you're having to talk to somebody. I had to talk to, believe it or not, a commissioner the other day, and they said, so what is FASD? And this is a commissioner with an ICB. And I was very happy to explain in layman's terms what FASD is. How would you explain FASD to somebody, a solicitor that knows very little about FASD?
How would I explain it? I mean, I think I would start by saying FASD is a complex neurodevelopmental disorder, a lifelong neurodevelopmental disorder that's caused by an alcohol-exposed pregnancy, when a child's been exposed to alcohol in the womb. And it's something, I think, something that I always sort of bring up, particularly because I'm often dealing with very young children or babies even, and toddlers in the care proceedings world, that just because a baby looks okay at that point doesn't mean they're okay, and we could rule it out. And I think that's a common misconception. So I talk about the fact that FASD often doesn't become apparent until a child is school age, when you start to see some of those difficulties come online more. And I often talk about FASD as almost like a syndrome. So you've got, it's an umbrella primary etiological diagnosis under which a lot of different conditions sit, including autism, for example, ADHD, a very spiky cognitive profile, executive functioning disorder, poor adaptive functioning, and those kind of things. But I talk about those in terms of stages, because things like executive functioning, for example, exists on a developmental trajectory. As you know, we don't expect any 2-year-olds to have very good executive functioning, but we expect a very different level of executive functioning in a 10-year-old. And so I talk about the fact that you often don't see the deficits until for example, the frontal lobes of prefrontal cortex of a typically developing child are coming online increasingly, and those of a child with FASD are beginning to lag behind, and that gap begins to widen. So in court reports, for example, where I suspect that a child may be presenting with FASD, I'm always very clear to say, actually, a watch and wait approach needs to be taken, even if they appear okay at this time. When this child becomes sort of school age, and if you start to see these difficulties and this kind of thing, this is when you need to, and this is what you need to do, and this is where you need to go.
Yeah. You've also got to be able to explain to people about age disparity, and at a young age, that's very different to teenagers going into adult services, and discussing age disparity. Then, is that something that comes up in your assessments as well?
Do you mean in the court assessments?
Yeah, being able to explain the behaviours and managing, parents' assessment as well.
Oh, absolutely. And I think a lot of the difficulties there can be is we're working with very traumatized children a lot of the time, and traumatized adults as well. And it's very easy to put everything into that and say, well, that explains everything. And the problem with that is that everyone then stops looking, and stops being curious about why. As soon as we call it trauma or attachment disorder, everybody thinks every symptom is under that umbrella. And I'm very, very clear in all my formulations in my court reports, for example. I deliberately put a chapter, if you like, or at least a paragraph on neurodevelopment and my concerns around that, and how that needs to be separated out, and how we need to understand that, because actually attachment problems and disorders and attachment behaviours look very different in children and young people with FASD as well, compared to young people without FASD, and our expectations need to be very different in that sense too. So I'm always trying to pick that apart. And the other bit I see quite a lot is often it's not necessarily considered that the parent themselves, who is struggling with adaptive functioning, making appointments, keeping to a routine, following the directions of a PLO or a child protection plan, may also have FASD themselves. And often, again, these parents may have picked up diagnoses such as EUPD, and other sort of diagnoses. And not to say that isn't necessarily the case, but actually there may be organic etiology there too that's been missed. So I'm always trying to trawl backwards and think, is there something here as well about why this parent's, and often we're asked to do perhaps a cognitive assessment, which is fine. But as you know, IQ alone doesn't predict functioning in individuals with FASD. So you need a lot broader assessment if you're looking at FASD than just an IQ.
Yeah, you mentioned earlier about misconceptions. I want to come back to that, if I may. What are some of the other misconceptions that you might frequently come across about individuals with FASD and the behaviours around those?
Are we still talking in the court world?
In the court world, but also, in general as well, because, FASD is a big part of your world in assessing for it as well. And we frequently, as a charity, we come across a lot of misconceptions with understandings of FASD. What are the ones you come across?
So I think in terms of if we do court first, I think, again, some of the misunderstanding is viewing these difficulties in adaptive behaviour or emotion regulation as purely behavioural.
Yeah.
Or purely relating to trauma, as I said, and therefore assuming that either it's willful and therefore can be stopped, or it's all attachment and therefore X amount of therapy will fix it.
Yeah.
And I think that goes on, that sort of goes quite nicely into the other bit in terms of working with many adoptive families. The misconception can often be, and it's all well-meaning, but if FASD isn't well understood and those behaviours in terms of poor emotion regulation and all of those kind of things that you see in children with FASD are misunderstood as just being relating to attachment and trauma, adoptive parents are so often, provided with therapeutic parenting courses and sort of information around all of that kind of thing. And of course, that's, ideal for traumatized children and all of this, and I don't want to underplay that. But the expectations when that child has FASD will be very different, and so will the outcome. And time and time again, I hear adoptive parents feeling as though they've failed because this parenting that they're doing beautifully isn't bringing about the outcome that everybody says it should. Yeah. And that's because this behaviour is coming from a different place. So that's a really common misconception. If you just put enough therapeutic parenting in or just enough therapy, then this will change it, when actually we're talking about a brain injury. So we've got to have completely different ideas about that. And I think going into then sort of the teenage years, there are, I suppose, common profiles that I see is young people who are either falling into trouble with the law because and being exploited because of the level of suggestibility that they present with. And being exploited into then sort of, as I said, getting in trouble themselves, but also in terms of relationships and those kind of things as well, and falling into inappropriate relationships and not recognising. And I think one of the things you see with children and young people with FASD is that perseveration in doing the same thing time and time again, despite the fact that if you sit them down in a regulated, calm way and you talk to them about it, and they'll say all the right things and then do the same thing again the next day and not really be able to explain that perseveration, but that's what happens. And it's a similar thing you see, talking to teachers at school. Well, they did this behaviour, we talked about it, they said they know why it's wrong, they seem to have insight, and yet they did the same thing an hour later. And it's that misunderstanding that this is a brain-based thing again. And that leads me on to another thing that I again, with school, often speaking to teachers, and what can often be a misconception is that children and young people with FASD can, because of the sense that they can present more able than they often are, particularly those with sort of quite a high IQ despite those executive functioning deficits and that adaptive behaviour problems, they can often verbalise a plan of action and say, this is what I need to do, I'll do this, this and this. And I see this in clinic when I'm doing the assessments as well. I mean, there's certain assessments that I do where you can literally see this happening.
Yeah.
They'll formulate a perfect plan, but then they can't follow it through. And they don't put it into act. They either don't do it or they do something completely different.
And because task initiation, knowing where to start, it becomes overwhelming, doesn't it?
Absolutely. Or it just becomes chaotic and the response becomes perseverative and stuck or whatever, and it all falls apart. And the problem is if you don't understand that in terms of sort of, executive functioning problems and all of that kind of thing, it looks like willful behaviour. It looks like can't be bothered or messing around or surely not, and that's something I sort of talk to teachers about quite a lot, that kind of discrepancy between what they appear to be capable of, what their IQ might say, and actually their functioning.
You mentioned earlier about the spiky profile, and this is something that I think a lot of people need to understand a little bit more. They don't often come across a spiky profile like this, do they? No. So can you explain more specifically in your terms what a spiky profile is, and then how it presents with our individuals?
So in terms of the neuropsychological assessments I do, if we look at, first of all, the first thing you do is an IQ test, if you like a whisk or a waist, depending on the age of the child or young person. And that's the basic sort of cognitive assessment. And that looks at verbal skills, what we call verbal comprehension. It looks at non-verbal skills, visual spatial skills, fluid reasoning, working memory, processing speed. So it looks at these different domains. Now, if you've got a neurotypical child or young person, if you were to line up their scores in all these domains, they'd follow a relatively flat or slightly wavy line. There wouldn't be massive discrepancies between them. When you've got a spiky cognitive profile, it generally alerts you to the fact that there's neurodevelopmental something going on. And, this is at its most spiky when it's FASD.
Yeah.
And the spiky profile is where you've got, instead of this general flat line or slight waviness, you've got spikes like this. So you've got peaks in ability or relative peaks in ability, and then you've got really significant deficits. So it takes on this sort of look rather than this sort of relatively flat line. The problem with that then is that the IQ score, if you've got what we call two standard deviations between these different scores, the IQ score is often not clinically meaningful and shouldn't be reported because it doesn't really tell you anything. If you've got a score of 105 here but 70 here, something in the middle of that doesn't tell you much at all, and it actually can be really misleading. So the spiky profile is that the discrepancy in those different cognitive domains, and then you don't just do this sort of basic cognitive test, but you also look at things like memory. So you can see spikiness even in memory, where you can have a child with episodic memory that's much stronger than working memory is the most common. And often, even in working memory, you'll see, if we're talking textbook, auditory working memory is much weaker than visual working memory, for example. And so there's a spikiness again, even within that memory profile. And then you go on to looking at things like language. And you'll have, most commonly, again, you'll have a discrepancy between expressive and receptive language. So, some children with FASD will have expressive language problems as well. But most commonly, you will have a child that's very verbal, but their understanding of language is much poorer. And often that ability to talk the talk is both a blessing and a curse because it disguises or masks the difficulties that they have underneath that, and the fact that they're not really understanding the social world in the way that they may appear to be. And that's particularly tricky when that young person, is an adolescent and that kind of thing. And then you've got the executive functioning problems. And the executive functioning bit is really, really important because if where you can get an IQ score in a whisk or a waist, if there isn't a huge discrepancy between scores, you still often, most children with FASD have near normal IQ-ish within a spiky profile or near normal skills. Some children will have a learning disability, but the majority won't. And yet there's a huge discrepancy. Again, if we go back to a neurotypical child, if you like, if you do their IQ and say they have an average IQ, you would expect their executive functioning skills to be average too, and you would expect their ability to function in the world to be average. Everything will kind of track on. So therefore, in a typically developing child, an IQ test would predict their functioning and would predict their academic achievement and their social functioning and everything else. The problem is when you add FASD to the mix, it doesn't do that. And you've got an IQ that might be near normal, but you've got executive functioning down here. And the executive functioning in conjunction with those other impairments creates a very poor adaptive functioning profile, where that young person has poor independent skills, they're vulnerable socially, they're not able to meet their own self-care needs and all of those kind of things. So that's what we call that adaptive functioning stuff, which you tend to comes into play more from sort of secondary school onwards, where you start to notice those kind of difficulties with planning and organisation and self-care and the sort of social vulnerability side of things.
And of course, we throw into the mix. We've got a question here that's come in that I think is really relevant at this point. Is you throw into the mix a lot of our FASD people have come from social care backgrounds, as you mentioned earlier, also adoption as well, and so there will be ACEs, there will be trauma, there will be a multitude of other problems that they have to contend with. How does that look different with someone with FASD?
Absolutely, because if you, where shall I start with this? Lots of things to say. with a child who has suffered trauma and ACEs, as you say, and has attachment difficulties, you're going to see some of those difficulties with emotional regulation and social relationships and all of that kind of thing. You're going to see some of those hot executive functioning problems, if you like. How FASD looks different is the severity and the diffuse nature of the deficits that you see. And you wouldn't see that in a child with trauma alone in the same way.
Yeah.
And it's quite important to also consider that a lot of these studies looking at the neurobiological effects of neglect and trauma have failed to take into account possible prenatal alcohol exposure. So actually, some of them don't really know what they're measuring. And I would hesitantly argue that they might not be measuring what they think they're measuring. So I think that's something to think, to take into account as well. The thing as Raj's studies show as well, in terms of looking at the studies that he and his team have done in terms of level of trauma, if you like, or placement moves as a proxy for level of trauma and neglect and that sort of thing, and neurodevelopmental functioning in FASD, his studies found that there was no significant difference between those children who'd suffered high levels of trauma and those who'd suffered minimal, which demonstrates again the fact that it's the alcohol exposure that's actually creating these neurodevelopmental outcomes more than anything else. I would always argue that a child with FASD, regardless of the level of trauma they've experienced, needs to be treated and supported with FASD as the headline, because that's not only the bit that's most predictive of their functioning and needs, but it's the bit that's going to dictate what kind of therapy and support they're going to respond best to, and parenting and everything.
Totally. And that leads us beautifully onto parenting, because in an FASD and family law, with the implications of FASD in that, how does FASD impact parenting abilities?
In terms of an adult with FASD?
In terms of an adult managing the behaviour. So if it's a court case that you're having to assess suitability for parenting at home, what would you be looking for there? What are the challenges that parents will be facing?
So, parenting a child with FASD is extremely challenging. And essentially, and this is what can be particularly difficult if we go into the care proceedings world, is that children with FASD need almost better than good enough parenting, because it's so challenging. And it requires parents who are able to regulate their own emotions and their own emotional responses to a huge degree, which is really difficult as a parent, full stop. Because the profile of FASD is one of chronic hyperarousal, agitation, hypersensitivity to the environment, difficulties regulating internal states because of damage to the HPA axis, the executive functioning problems and that kind of thing. So the parenting and support that a child needs externally is what's required in order to help them be as regulated as possible, because that's the bit that they can't do independently themselves. So you need, in an ideal world, a child with FASD needs to be growing up in a family that's sort of low in emotional arousal, if you like, and be able to provide as consistent and predictable an environment as possible. And the expectations need to be different. And I think this can be really tricky. And for many adoptive families, it's a journey, because often the child that they adopted and imagined how things were going to be if they didn't know the child was going to have FASD are going to be quite different when they learn that that child or young person has FASD. And that also includes how they parent them. And it's about being kind to themselves as well, because actually they could be the most wonderful parent ever. It's not going to stop these emotion regulation, for example, difficulties, because that's something that's relating to the brain injury. So it's more about adapting expectations as to, okay, this is how it is. These are the bits that are going to optimize my child's functioning and their ability to be regulated. But this is going to still happen, even if I was the most perfect parent in the world 100% of the time. It's about the support and accessing support themselves as parents as well, from other parents, with organisations like yourselves and other organisations where parents can speak to each other and understand they're not alone in it. I think it's really, really important.
We had a support group, a parent carer support group earlier today, and I happened to mention something that was brought up to me, where we did a Q&A with Raja a couple of months ago, and we were in this lecture theatre, and one of our ambassadors for the charity, he was sitting in listening to Raja talk, and in the car on the way home, he was saying to his carer, he said, I kind of get it a little bit more now. He said, so this part of the brain is working, this part of the brain's working, but this middle bit is having all kinds of problems. He said, and that's where you are, Mum, isn't it? You're that person in the middle there. And it was a real clear understanding for him that actually the mum in the middle part of the brain was tying up these two outer parts and being that support network that made sense of things, or tried to make sense of things. Now, that is a complicated procedure, a complicated job at the best of times, let alone having to manage all these other elements as well. And as you say, the regulation, when you're writing an assessment in a court proceedings, how does that come into play?
In terms of the child's emotion regulation difficulty?
Yeah, and the suitability of, would it be about the suitability of a parent staying custodian of that child?
Yeah, it can be. So if there's a child with suspected FASD or known FASD, and as to, if it's in care proceedings, and I've done a psychological assessment of either the whole family or just the child, or sometimes everyone. I suppose what I try to highlight is the fact that the emotion regulation difficulties, as I said earlier, may not just be related to trauma and attachment stuff, but it's also organic and relating to FASD or suspected FASD. And therefore, I would suggest that what would need to be considered is whether the parent or caregiver or in question would be able to manage those difficulties in the long term, in order to optimize their ability to function and reach their potential, or whether that parent or carer's own difficulties could potentially create a situation where that child with FASD is not going to manage very well in that environment at all, and it would struggle more than your average child, if you like. So it's obviously not my role to be directive in saying this is what should happen, but it's about picking apart, laying out the possibilities there, in terms of the reason for the behaviour may be twofold, and one may be amenable to this therapeutic input. The other would also benefit from certain therapeutic inputs, but also there needs to be an understanding that this might also, or is likely to be, a long-term situation, and that the needs of that child are likely to evolve and in some cases increase over time in certain areas. And what needs to be considered is whether this particular parent or caregiver will be able to meet those needs as they evolve, given their own set of needs and the circumstances and that sort of thing. So that's how I would normally map it out.
And that would be how. So, as an expert witness in family law, you know, we started the question: is FASD overlooked in family law? Is FASD overlooked in family law in your experience?
I think it just remains not understood enough. Is the key thing.
The diplomatic answer, yes.
Yeah, I think it's just a case of, just like in all other areas, ensuring the message gets out there in terms of what FASD is, how getting rid of the misunderstandings that it's only if, huge amounts of alcohol consumed in pregnancy or in this situation or that situation. I think it's just about ensuring all different agencies get the message about FASD, and what it means and what it might look like and how that impacts every system within sort of family law, if you like, and also how, I always try to write in court reports, as I said, in my neurodevelopment section, and if I'm suspecting FASD, I will speak about if this child isn't returned to their birth family, and we suspect FASD, it's very, very important that known prenatal alcohol exposure is put into their child permanence report. It's very important that this information is carried through into their adoption paperwork, because this would mean adoptive parents would be able to seek a diagnosis if needs be later on. So a lot of what I feel like I'm doing is just making sure that message filters through into the next stage for that child, so that it goes on with them in their journey and isn't mislaid somewhere. I think one of the other, it's improving, but the misconception is often that drugs and substance misuse is far worse. And so that's often very readily reported, but the alcohol historically has been more likely to be missed. And so again, it's putting that message in, and I end up extending my reports longer, sort of talking about just, actually alcohol's the most damaging, the most teratogenic substance during pregnancy, etc., etc.
Do you find that when you're writing the reports, people are coming back to you and going, right, okay, this is a lot, but why are we not hearing more about this? Do you get that feedback a lot?
I think one of the things with the court reports is often you don't get much feedback at all, if any.
Right.
Unless you're asked to attend the final hearing to give evidence, and you don't do that in all of the assessments that you do. But certainly there's more and more that will come back saying, and how do we get this assessed then? And actually, interestingly, I'm having some cases where they're literally asking for assessments within the court process, which is really promising.
Absolutely.
And that's been something that's, I think, inquiries about that have really, there's been an uptick of that in the last sort of 6 to 12 months, I'd say.
Yeah. Do you think that's off the back of when the nice quality standards came out, people took time to assess them and to analyze them and see what they needed to do, and then the follow-up, there's been more people are understanding FASD, and the more people that understand FASD, the more questions come up. And so therefore, and this is in all sectors, Gilbert as well, where we're doing a lot of work on FASD in the criminal justice system, and you talk about suggestibility, and we've dealt with confabulation as well, and the influence of that now and the impact on that. But when you're dealing with all different sectors and it's beginning to filter through, are you concerned about a floodgates opening? at some point?
I mean, I think
when we're looking at assessment specifically,
I think there will be, and there is becoming that, and I think that's why things like the hub and spoke model are so important, because there still aren't enough services to cater to the need. Equally, I understand that community paediatric services are already overwhelmed just with dealing with autism and ADHD.
Yeah.
So you can see why the anxiety is there. So I think, yes, there is going to be a floodgate. There is becoming, I think it's there. And I think that's why it's so important for, well, not only, you only want organisations who are doing it properly. That's one of the most important bits. But also, widening the hub and spoke model is so important, because that's what enables local services to be able to provide that support in the most pragmatic way, and then carry that understanding through to their own teams, and that sort of thing. So yes, I think there's certainly going to be that, and there is that, and because we know obviously FASD is significantly more common than ASD, it can only be that. I feel like we're sort of the ASD 30 odd years ago with FASD.
Say 30 now, yeah.
More than that, but it is that sort of sense, isn't it?
Yes, absolutely. I think, we're looking at, having set up the charity some years ago, we're seeing the families that were really struggling when they first came to us. And we're seeing, and at that time there was a sense of doom and gloom around a lot of things, because there wasn't a lot of hope in anywhere. I always latch on to hope. Glass is always half full with me. And I think we are, as an organisation, as a charity, we're getting more and more requests for training in all sectors, which is fantastic. And we make a point of bringing in those with living experience, talking firsthand about what it's like to live with that experience and understand the behaviours. Because when you understand the behaviours, or when you understand where it came from and how it originated and why then those behaviours are as they are, and then learning how to manage the behaviors, I say manage, or live with those behaviors and have strategies and coping mechanisms, it leads to positive outcomes, hence the management plan in the nice quality standards. Talking about that management plan, I know when I talk to Raja about his assessments, he says the management plan is part of it in the recommendations that we write at the end of that assessment. When you write your assessment, because when you meet an individual with FASD, you meet an individual with FASD. So when you are writing that bespoke assessment, what are your recommendations generally to help their support network utilize that and try and get the support around that individual and that scaffolding that they so need?
Yeah, I mean, as you say, each child or young person with FASD is an individual, and they've got individual needs, albeit that there are some sort of common threads throughout. I always try to personalise it according to where they're at, according to their age, according to what's going on in their family, also according to their attachment needs, what therapy's gone on before, what they, all of those kind of things. So in a recommendation section of my report, I will have an education section where I will, and I always triangulate information I've got from families with schools and hear what schools have got to say and what, what they're already doing, so I can provide some recommendations about that. Whether I feel an EHCP needs to be reviewed in order to sort of provide more in-depth information about FASD on the back of my report, I often recommend that. So and sometimes that's keeping the child in their placement and supporting that to continue, or other times it's recommending that perhaps a different placement. And obviously, again, I have to stay in my lane. I can't say they need to go to this specific place, but I can say actually they're likely to benefit from somewhere, for example, that, you know, enables them to feel better regulated, for example, this sort of placement, or, you know, X, Y, Z. So I'll have those educational recommendations. I'll also often recommend specific training for schools as well, FASD training, if that's not been done already. Then I will think about therapies and what the child or young person has already had, or what they might benefit from, in terms of whether that's something like sensory integration therapy, whether that's one-to-one support around sort of social communications, or the risk of exploitation and those kind of things. But I'm very, very clear to emphasise that this stuff needs to be done through an FASD lens.
Yes.
And it's, again, that's something that I talk about in terms of the EHCP and the outcomes, because often I've seen some fantastic EHCPs, and I've seen some that I think, wow. And the outcomes, you know, this child in 6 months will be fine, essentially. And you think, actually, no, it needs to be, this child with FASD will continue to need this support in order to optimise their potential in this area. Not that they'll have this for 6 months and then it will be removed. It will need to be reviewed and perhaps changed with their evolving needs. But
Yes.
actually, it's the sense that this scaffolding needs to remain in place.
Absolutely. Throughout their life.
Exactly.
Yeah. And when we look, sorry, I was just going to interrupt for a second, because a question came up that I think we could fit in here, is about the assessment itself. If somebody has one of the comorbidities, or several of the comorbidities, but they have come to you with a diagnosis of ASD and ADHD, you see that there are signs that steer clearly towards FASD. How does that work for you when you're making an assessment? Is that a common thread for you?
Yeah, I mean, a lot of the time, locally, families have managed to get the ASD diagnosis and an ADHD diagnosis, but they feel that it's not answering all the questions. And they'll come, I mean, a lot of children I see have come with a whole collection of diagnoses, but it still doesn't quite answer everything. Like, lots will have dyslexia, dyscalculia, you know, lots of different neurodevelopmental diagnoses. But yeah, so that's very, very common. And then, I mean, the clear thing is the history. You need to be looking at the history, and looking for whether prenatal alcohol exposure was a thing in there. And obviously there is a large section of adoptive families who, frustratingly, there's that suspicion, but there's nothing documented. And that's the only time, of course, when sentinel facial features come into play clinically, because that's
that overrides everything.
Yeah. But aside from that, for the majority, 90%, that's not the case. And therefore, you're looking for that history. And we'd be pragmatic, and you need either confirmed history or a very clear set of circumstantial evidence, that there was a history of chronic alcohol misuse before and after the pregnancy. And, you can be pragmatic if there's a really significant amount of circumstantial evidence there. But if there's nothing, it's very difficult.
And one of the questions that is being asked now is, in antenatal clinics, is about, what was your lifestyle like prior to finding you were pregnant? Because that way you get a clearer indication of the behaviors, and there's a suggestion in there that you could have that. What would the diagnosis look like? We've got questions that, if you don't have that evidence, but because they've got significant impairments in many of the key areas, what would that diagnosis be called? Or would you not have a diagnosis?
It's very difficult. You always have to think, and this is with my court hat on, you got to think, could I stand up in court and defend what I'm writing in this report? And that can be really tricky for families, because, of course, the diagnosis opens up understanding and support and those kind of things. So you've got to balance that up. As we said, if there's really strong circumstantial evidence, we will diagnose FASD if it's strong enough. If there's nothing written down, you just can't, unfortunately. No. If there's a small amount, you know, if there's enough to suggest, you know, you can sometimes say likely or suspected FASD.
Right.
And and then I would, in those cases, I would put and would benefit from being supported, as though this, you know, with this diagnosis.
Yeah.
And write very clearly what the needs are within a report. And that's a way you can sort of get around it, saying, you know, put the support in for this. They're not going to lose out. And, you know, this is going to be in their best interest. If you've got no evidence, it's very, very difficult. If you've got nothing written down.
So when you know this, because this is a key area, isn't it? What work is going into explaining this to midwifery teams and working with antenatal clinics and working with pediatricians early on? What is going in to say, look, we need categorical evidence? And where is that documented? How do they document it? Where do you recommend that it is documented?
I mean, I don't know exactly what you know, the process is at the moment, but I mean, my recommendation would be, as you suggested, from the get-go. Well, first of all, the education out there in the first place about not drinking alcohol even when sort of considering becoming pregnant. But in antenatal clinics, I think, I mean, even in my own experience, I mean, it was some time ago now, but you know, I don't even remember being asked. I think I ticked a box saying no. Do you drink alcohol? 0. I don't think it was ever even brought up. And I think it's really important to have those conversations about lifestyle before becoming pregnant, and in a way that does not feel shaming, in a way
absolutely
very, you know, and also you can be very careful about asking, so when did you find out? I guess you were just carrying on as normal until that point. You know, you can put it in a way and that, you know, that can make it feel easier for a mum to sort of say, goodness, yeah, I didn't find out until, you know, I was maybe 10 weeks and, you know, I did go out a few times. Obviously, you know, it opens up that conversation in a way that doesn't feel shaming. And that's the really important bit.
Absolutely.
And I think then that conversation needs to keep going throughout the pregnancy, not just a booking conversation. It's something that needs to keep going. But again, as you said earlier, it's about ensuring all these different groups of professionals and agencies are upskilled in terms of understanding about FASD, because there are still gaps. I think it's getting better and better all the time. I'm certainly, you know, seeing that. I'm sure you are too.
Yeah.
And particularly in social care, you know, there are social care teams I work with all the time who are absolutely fantastic on FASD now. And that's just fantastic, because that's been something I've really seen evolve over the last 5 years or so, I'd say. But there's still a lot of misunderstanding out there in certain areas. You know, I've heard certain people working with pregnant women saying things that you think, oh my goodness, I need to go and undo that in an email immediately. And you know, it's really difficult to hear that.
I want to talk about transitioning. I sat on or listened to today the webinar with the new neurodiversity group on neurodiversity in the criminal justice system, and there was a big steer towards schools understanding FASD, or not necessarily. They weren't talking about FASD. Unfortunately, I wish they were. They didn't include it at all in the whole conversation. However, when we're looking at neurodiversity, they were explaining that schools really didn't understand the behaviours, and so therefore it was the amount of expulsions that led to the likelihood of entering the prison and the criminal justice system. And we see that a lot with our individuals, with the vulnerability that you spoke about earlier. At what point do you feel with transitioning assessments should be updated? What are the key times and periods that you think families should really push for assessments?
I think a really good neuropsych workup is really helpful just at the beginning of or prior to going to secondary school or secondary provision. And then at that sort of 16, 17, 18-year-old stage. depending on where that young person is at. So, for example, a young person in care, 16-ish, would be very important to do, right? So I think those two are really important. Often at diagnosis, say, for argument's sake, that child is diagnosed at 8 or 9, an updating assessment just around secondary school, and then again just approaching adulthood are the key times.
Yeah,
I think.
And without that, because as you said, that support, that diagnosis, the importance of that diagnosis early on, with that recommendation, the recommendations and the support plan that should steer throughout their life, but it has to be assessed, doesn't it? Because there are regular changes at different points in their life, as you just pointed out there. So when we're talking about positivity, where do we go to get diagnosis? What's the process? What's the best way of gathering the information, get those collation tools that we've spoken about before on these webinars? But when you've got the information that you need and you have a child in care, or you have an adopted child that is presenting with a lot of these signs and symptoms and behaviors, how do you go about getting the diagnosis in the first place, this crucial diagnosis?
Well, in an ideal world, obviously, you'd be referred to local community paediatric team.
From your GP?
Via the GP, or sometimes via the school.
Okay.
And then the community paediatric service would be able to look into that, or at least look into some of those other possible sort of comorbid diagnoses as you were talking about. I can't speak for every region in the UK because every area is different in this sense. Yeah. There are still some areas, obviously, where a child needs to be referred in for possible social communication disorder rather than possible FASD. Yes. And then the FASD comes sort of within that. Obviously, those areas that are part of the hub and spoke model could then potentially, if further consultation is required, they could access that. If community paediatricians feel confident in diagnosing, they can do that within that service. There's also obviously the tertiary organisations like the National FASD Clinic and other organisations like ourselves who can provide diagnosis, assessment and diagnosis as well. So it really varies depending on where the child is and the services around them in terms of where to get that assessment, if that makes sense. But
what about an adult's needs assessment? What would be the best approach for that?
So do you mean an adult who's got a diagnosis already?
No, that hasn't got a diagnosis, but is looking for a diagnosis, or even if it's suspected, but they need to get an adult's needs assessment to be able to support them.
Okay. Obviously, the Surrey Clinic assesses adults as well. In terms of an adult's needs assessment, that you'd be looking for a neuropsychological assessment, which would my clinic does that for adults as well. There are other clinics available.
Yes.
And what they need is a full neuropsychological workup, as I said, not just a cognitive assessment looking at IQ, but looking at all of those things like executive functioning, adaptive behaviour, ideally language as well, and things like suggestibility and those sort of vulnerabilities. So that's where they would need to get that assessment, looking at all those areas. And then if there is, for example, a history of prenatal alcohol exposure, you could be looking at whether those difficulties sort of map onto and would meet diagnostic threshold on the basis of that. And
with your upskilling of, because I know you do a lot of training as well, you offer expert training as well. When you're delivering that, what is your message to, who are you delivering it to, first of all? What would be the main area that you'd be delivering it to?
I do lots of different training. So I do training for individual schools. I do training for whole virtual schools. I've done training for virtual school heads. I've done training for social care professionals, medical professionals, and also workshops for adoptive and foster parents. So obviously the message is slightly different depending on who that is. In, like, for example, the workshops with parents focus a lot on behaviour and parenting and all of those kind of things. With school, I'm looking at sort of understanding what FASD looks like in school and how you support that, and emphasising the fact that it's not a behavioural problem, even though it looks like one. And all of those kind of things, how executive functioning problems look in the classroom. With social care, what do I focus on? It depends on the team. Obviously, if I'm speaking to leaving care teams, the emphasis is on the needs of making sure you understand that what you see is maybe not what you get. And, you know, you could have a very vulnerable young person who can talk the talk and needs you to believe they can do it all. But actually, if, you know, they can't, and you need to be able to evidence. You know, don't just put them out there in semi-independent living and assume it's all going to be well. And so I'm talking about how a FASD looks at that stage and what you need to do to ensure that you're, you know, or what suspected FASD, because lots of these young people don't have a diagnosis, but, you know, so it's about what to look for. And always to say, if you suspect it, look back in their history. Just look back in their history and seek assessment. And then with adoptive, so for its sort of post-adoption support teams and that sort of thing, it's looking at supporting families with parenting, what kind of therapies and input helps, how to access assessment, and all of those kind of things. So it's sort of, I tailor it depending on the needs, really. But the key message is in supporting young people, ensuring that scaffolding is something that it's understood that needs to continue. And as you say, also about being optimistic as well, because actually appropriate diagnosis and appropriate support completely changes outcomes for children and young people. And that's the really important message. You know, it's about reducing those risks that not having a diagnosis, you know, it might involve potentially.
Absolutely. Listen, I think it's a perfect place to end with a positive upbeat. Thank you, Cassie, so much for your time tonight and clearing up a lot of these questions that I think people, families, those that are working alongside FASD, these are the questions that a lot of these families being able to feel positive about how they move forward. And it is about understanding the condition, how to work with those behaviours, and having a management plan and a strategy that supports and scaffolds them throughout their life with constant assessments and updates to be able to work with that family to lead to better outcomes, which is what we're all looking for. Cassie, thank you so much for your time tonight. Really appreciate it. I'm sorry if I haven't been able to answer all the questions or get all the questions to Cassie. However, we will be covering many of these same questions in previous webinars. We would have covered them, or in future ones as well. So thank you for taking the time for us tonight. Thanks again, Cassie, and hope to see you again. All the best.
Thank you very much.
Good night, everybody. Thank you.